Thank you. As Steve mentioned, I'm Tess from the London School of Hygiene and Tropical Medicine. I'm a research assistant and recently enrolled PhD candidate as well. So thank you for inviting me to present and for the opportunity. I'm going to talk about one of the projects I've been working on for the last year about the need for primary eye care in the Rwandan population. So just as an overview of what I'm going to talk about today, I'll give some background about visual impairment and primary eye care. Then I'll talk about the objectives of this particular study, our methods, results, conclusions, and the next steps. So talk about the background first. Oh, that's not come up properly. So visual impairment, many of you will know what it is already. I see a lot of people in the room wearing glasses. This is also known as vision loss. Just to give you an example, here's a street in Kyoto. On the left-hand side is a clear vision, and on the right-hand side is what someone with moderate or severe vision loss might experience. So very blurred. Visual impairment is a major public health problem. Around 270 million people in the world are affected by moderate to severe visual impairment, and that's quite hard with those quite large numbers. So that's around 2 times the size of the population of Japan, I believe. 80% of visual impairment is preventable or curable through public health interventions. And 80% of people with visual impairment live in lower middle income countries where the resources are the least. Visual impairment has a profound impact on individuals through factors such as poorer educational attainment and then lower opportunities with employment, which in turn affects the family and society. The major causes of visual impairment include cataract at 18%, and this is from the Global Burden of Disease study in 2013, and uncorrected refractive error also makes up a huge proportion of the global causes. Uncorrected refractive error is where images fail to focus on the back of the eye. A lot of people in the room probably have this condition or know someone who does. And it can be simply corrected through the use of spectacles. Something else which is very common is age-related vision loss, or presbyopia, which affects about 670 million people globally, and this will be increasing as well with global ageing. As I mentioned, simple interventions exist such as glasses provision and cataract surgery for dealing with visual impairment. However, access to these services is a huge issue. For instance, spectacle coverage is very low, particularly in Africa. It ranges from 7% in the Gambia to 54% in Botswana, and that's for reading distance vision glasses, which I will probably be alternating between the use of uncorrected refractive error and distance glasses. So that's for distance glasses. For reading glasses, the coverage is even lower. So that's with the age-related visual impairment, it's even lower. So 0.5% coverage of that intervention in Tanzania. Cataract surgical coverage is also very low at 52% across Africa. Vision 2020 is a big initiative that was established through a partnership through the IAPB, the International Agency for Prevention of Blindness, and the World Health Organization. And it started in 1999, and it was a big initiative to try and reduce this large burden of visual impairment across the globe. It's been going for a very long time, and more recently they put together something called their Global Action Plan, which has a big focus on universal access to eye care services. So why am I telling you all this? I wanted to give you a bit of background so that I can talk about primary eye care and what it is. And one of the focuses of the Global Action Plan is to try and provide primary eye care or eye care at the primary level, such as at health centres, through a task-shifting approach. So primary eye care is where basic eye care services are delivered at the primary level, as I mentioned, by general health care workers, and it's integral to trying to improve access to eye care. However, it is not very well known what the burden of the conditions that can be managed in the primary level is in many countries, and that's why we wanted to do this study. That's one of the reasons behind it. To give you a little bit of context about Rwanda, it's a small, very small country in East Africa with a population of about 11.6 million. Life expectancy is 64 years. It's a predominantly rural population with pretty high community-based health insurance coverage. In terms of eye care professionals, there's 16 ophthalmologists and 65 ophthalmic technicians, and these professionals work at the tertiary and secondary levels, but not at the primary level. And it's a very beautiful country, just to give you a look at what it looks like. In Rwanda, a primary eye care program has been initiated through a partnership between an NGO called Vision for a Nation, and they've done this in partnership with the Rwandan Ministry of Health. They developed this program alongside, in partnership. They've developed a curriculum which involves training general healthcare workers to provide basic services, and they also provide supervision and refresher trainings. The components of the training are measuring the clarity of vision or visual acuity, examining eyes, prescribing and dispensing glasses, and managing basic conditions of the eye, referring patients on, and providing some basic education. So now on to the objectives of our study. So London School of Hygiene and Tropical Medicine was asked to run an independent evaluation of the program. That was the Vision for a Nation Ministry of Health supported program. This involved various components, including understanding what the need was for primary eye care in the population, what the impact of the program is for the beneficiaries, and how well the program is working. So today I'm going to focus on what the need for the program is, as I mentioned. So what were the methods that we used? Oh, before doing that, I'd like to declare my role in the study. I was involved in designing the data collection tools, doing a lot of the project administration, spent a lot of time in the field, and some of the formal analysis alongside others. So we did a nationally representative population-based survey in 10 districts of the country between September and December of last year. We evaluated or interviewed and examined all people living in our study areas who are aged 7 years and older. We estimated the sample size to be 4,800 people, so that was our target based on this calculation. In terms of the sampling, we did a two-stage sampling. Firstly, we selected districts and clusters or villages using probability to proportionate to size sampling with the Rwandan census as our sampling frame. I noticed a mistake on this slide, I'm sorry. It's actually 50 clusters of 96 people per site. In the second stage, when we selected the households within the clusters that we'd selected, we used compact segment sampling, and all people within our selected area were asked to participate. This is another mistake on this side, I'm sorry, that all eligible participants were enumerated and they were screened within their homes, not asked to attend screening. So this is a photograph of the districts that we selected across the country. As you can see, it's quite a small country. And within each of those districts, we selected 5 villages using probability proportionate to size sampling. And here's a photo of the next stage of compact segment sampling, where we firstly mapped out the villages and then chose randomly a section of that village to sample. Here's a photo of the team, some of the team we trained to collect the data in each of those districts. So in terms of the outcome measures, as I mentioned, we wanted to understand the prevalence of the need for primary eye care. And the secondary outcomes, we also wanted to understand what the knowledge and attitudes were around eye care in the population, which we did in a randomly selected subsample of the 4,800 people. As I also work in disability, mainly we wanted also to understand a little bit around what other self-reported difficulties people are experiencing, such as hearing, walking, self-care and communication. So in terms of the need for primary eye care, what was that made up of? We used the Rwandan curriculum that was developed for this program to define this outcome. It was made up of 4 main components. The first was the need for reading glasses in those aged 40 plus, because that's where the problem commonly begins. Then the need for distance vision glasses. And that's in all ages. Then symptoms that indicate conjunctivitis type things that can be managed at the primary level. And then the need for referral onwards to secondary level for more complex conditions. So these were the components that made up that need for primary care. In terms of the measurements of those outcomes, we also used this Rwandan curriculum to determine how we were going to measure them. So for reading glasses, we used a near vision reading chart, which was in Kinyarwanda, which is the local language, and it also had numbers for the people who might not be able to read. For distance vision and the need for referral, we used something called the Portable Eye Examination Kit, which had been developed by researchers within the London School. It's a tablet-based vision chart that can be used quite easily in the population, and it's very portable. So here's a photograph of that being used in the field. In terms of whether vision could be corrected and people that could, if people could benefit from glasses, we used a pinhole occluder, which mimics the effect of correction with glasses. So if someone is wearing those glasses and then they can see very well with the peak test that I mentioned earlier, it means they have the possibility to benefit from glasses. But if they don't improve, it means they would need to be referred onwards to secondary care. And finally, for the eye symptoms, we measured this using a validated questionnaire, which asked people in the past week how troubled had they been by itchy, watery, sore, swollen or sticky eyes. And the answers range from not troubled to extremely troubled. We used the cutoff of very to extremely troubled to say that that was the need, where they would need primary eye care. The other outcomes, we used questionnaires to measure knowledge, attitudes and practice of eye care in the population. We also used this questionnaire to determine sociodemographics. And we used a tool called the Washington Group Short Set to understand about other difficulties that people might experience in the population around hearing, seeing, walking, and self-care. For the analysis, we used prevalence estimates for each of the outcomes, and we used logistic regression to look at some of the associations with the need, sex, education, socioeconomic status, and insurance status were the main ones. So now turning to the results. In total, we examined 4,618 participants and interviewed them as well, which was a response rate of 86%. In comparison to the population, we found that a high proportion of our sample were aged 7 to 16 years. A lower proportion were aged 17 to 24, and this was significant. Lower proportion were aged 25 to 39, and a higher proportion were 40 plus. We also had more females in our sample, and this reflects who might be home at the time of the population survey, as we did it house to house. So because of these significant differences, we age, sex standardized the results, the prevalence estimate, using the demographic health surveys of Rwanda as a reference. So in terms of the need, we found 34% of the population had a need for primary eye care in the population, which is quite high. In terms of what made up the need, we found 1.5% needed primary eye care for the referral, 2% needed it for distance glasses or uncorrected refractive error. The need for reading glasses in those aged 40 plus was very high at 33%. However, overall, if you look at all ages, that's 5%. And symptoms made up 28% of the need, or not, 28% of the population needed primary eye care due to symptoms. And there is some overlap, as you'll see in the next slide. So symptoms overlapped with uncorrected refractive error, referral, and reading glasses. So symptoms made up a large proportion of the need. And the types of symptoms that people were experiencing were itchy and watery mainly, with less common, lower proportions for those with sore, sticky, or swollen eyes. The outcomes that we measured increased with age, and I'll show you the results on regression later, but this is just to show that each of the outcomes increased with age. And the overall need, as a result, increased with age, with the greatest need being seen in those aged 40 plus. Also, females experienced a greater need than males in each of the outcomes. When we look at the logistic regression, and this is a very simplistic version of the results, but just to show that age and sex were, as I said, showed an increased need in each of the outcomes, which was significant. Except for female sex, there was no association with uncorrected refractive error, which is URE. There was no association with socioeconomic status or health insurance, but there was an association with higher education with the need for reading glasses. The effect sizes for female sex were between 1.3 for the odds ratios and 2, and for age it was much higher than that, around 5. Oh, sorry, going backwards. Okay. In terms of knowledge and attitudes of eye care in the population, we found that 80% of the people sampled were aware of refractive errors and cataracts, and 74.2% attended or would have attended the health centre for eye care. So people tended to know that you can access primary eye care at the health centre level. We also asked a series of statements and found that there was some misunderstandings around eye care in the population. We found that people tended to agree with the statement that it's normal to have poor eyesight when you get older, and that there's no treatment for poor vision in older age, which shows that there needs to be more education around this, around eye care. Just going to skip over those. So, however, a lot of people disagreed with the statement that eye treatment is more expensive than other treatments at the health centre. So they were aware that it was part of the normal healthcare service at the primary level. Okay. In terms of self-reported difficulties, we also found that these were very high amongst our participants. So hearing, walking, remembering, not so much self-care and communication, but overall self-reported difficulties in our sample was very high. So it's not only the need for eye care in the population that's important, but these other disabilities that might need to be considered as well. So in conclusion, we found that in a national survey of the need for primary eye care in the Rwandan population was very high, and this was driven mainly by symptoms of conjunctivitis and the need for reading glasses. The need was much higher in females and older people. So we think that primary eye care will have to target these populations in order to make them more accessible for these groups. There needs to be more community awareness about eye care, particularly around the misunderstandings about the no treatment for eye problems in older age. In addition to primary eye care, other conditions could be considered at the primary level, such as hearing, physical or mental impairment screens, to have a more holistic approach, given the focus now on universal health coverage and the focus on disability in the Sustainable Development Goals. So the next steps, we are doing the impact studies, which we want to understand the impact of uncorrected refractive error or distance glasses and the effect of the correction, and the impact of conjunctivitis treatment after 3 weeks. So this is some of the acknowledgements of the people who were involved in the study alongside me. Thank you very much.